So good evening, folks. Nice to see you all. Welcome to any new faces. Some folks join a few minutes after. As I said in the preamble, this is webinar number 1 of our spring clinical mini-series in dental sleep medicine. Our goal is to bring you relevant facts, techniques, technologies, and products that you can use tomorrow. Because I know we're all struggling to keep up with the latest things and what should we buy and not buy and what works. So you're going to be hearing from lots of folks who are in this full time and will be here to help us. So tonight I'm very pleased to introduce someone who I don't really think needs an invitation if you've been doing dental sleep medicine for any length of time. Braebon Medical in Canada, just outside of Ottawa, and Dr. Richard Bonato, who's the CEO and co-founder, is with us tonight, and he and his company have been great supporters of our academy since our inception. He's been a great supporter for me personally, and I know tonight he's going to be here to help you with any questions you might have. Dr. Bonato has been involved in the study of sleep and its disorders since 1986, has taught courses on sleeping and dreaming at Carleton University, has lectured on 4 continents, was the director of a sleep disorders laboratory, and has been an author, co-author, reviewer, and examiner in various educational organizations within the sleep field, including AASM, AAST, BRPT, and has served on the executive of the Canadian Sleep Society. Rick has a PhD and MA, and as probably you know, he's also and started out his field as a registered polysomnogram technician. Rick is the CEO and co-founder of Braebon Medical in Canada, and his topic tonight is the role of technology used by dentists for the diagnosis and treatment of obstructive sleep apnea. It is indeed a pleasure to welcome Dr. Bonato to our audience tonight. Thank you, sir, and take it away.
Okay, thank you, Dr. Rawson, for that introduction. When I lecture around the world and I tell people where I live, and I often say, well, I'm Canadian, and they would often ask me, well, you speak English, and what's the difference between a Canadian and an American? Well, it got to the point where I would explain myself and they wouldn't understand. So I finally just said, look, a Canadian is an unarmed American with healthcare coverage. And that's how I would get over all of that issue. But I live just outside of the city. I live in a rural setting. That's just Google Maps of where I live. Our issues where I live are more like deer and bears and fishers and coyotes. I was invited to write an article a few years ago. I think this was from 2018. If you want to, it's a 1.5 page article I wrote that was published in the Journal of Dental Sleep Medicine. And there was a letter to the editor. So this is a really good synopsis, if you will, of how I feel dentists should play an important role in dental sleep medicine. So much of what I'm going to talk about tonight is actually described in this 1.5 page. And I know this, when I wrote it, was widely circulated after I spoke with someone like the president of one of the sleep academies. So this evening, I'm going to talk about the role of technology used by dentists and what their involvement is in diagnosis and treatment of obstructive sleep apnea. And I'm also going to talk quite a bit about, from a sleep study perspective, what is the information, what does it really mean, and what is important when we talk about this, the data and the signals. So the objectives tonight, we're going to try to understand the role of dentists in sleep medicine, understanding what the signals and information means, identify and understand sleep disordered breathing, when to do a home sleep test, and what is important. And much of what I'm going to talk about is on this page, what we call the fundamentals of sleep and obstructive sleep apnea. So we actually give this out as a laminated guide. So if anybody wants this and you don't currently have it, I'll have my email address at the end of this presentation. We pass this out for free. And essentially what you have is the entire spectrum here, with normal breathing on the left-hand column. And as we move to the right, we proceed into flow limitation, obstructive sleep apnea, and hypopneas. And this shows you the cross-section of the airway as it narrows from normal breathing to apnea, what happens in the flow through of air, And then, of course, what we're going to be really looking at, the bottom two rows, what the signals actually look like when you have a home sleep test, or if you actually are able to look at the raw data from a polysomnogram. And what does this flattening mean here? I'll go into detail on that. What is this amplitude and further flattening in the plateau, and how that responds? So this is your raw data at the very bottom. We'll talk more about that in detail. So one of the reasons why are we here today? Well, for those of you who know Dr. Gilles Levine, he was at the past the Dean of Dentistry at the Université de Montréal. He is a world expert on bruxism. And, I've attended some of his lectures, and he would say, anytime you stick something in the mouth and you do not think about the airway, you have another thing coming. So it's really important that you consider the airway anytime you're working with patients, even if it's something as simple as a single arch maxillary night guard for treating bruxism. And in some of their research, they found that 5 out of 10 patients had their sleep apnea worsen when they used a single arch maxillary night guard. And that's important because anything in the mouth is going to occupy space. And if you have a night guard in the mouth, you can actually push the tongue farther back against the posterior of the pharyngeal wall, and that's going to set up a situation conducive for sleep apnea. Now, one of the reasons why it's important, people often ask, sleep, what the heck is that? Why is it important? Well, this is data from the American Academy of Sleep Medicine. And what they have calculated in their data is that the cost of sleep apnea to the US economy is $150 billion. So the Canadian economy being approximately 10% of that, we're looking at a cost in the Canadian economy. One could then say it's about $15 billion. Everything we're going to talk about, though, tonight is going to be about airflow and airway. The most important part, the first part of airway, is going to be the nasal pharynx. So here's a CBCT scan of myself before nasal surgery. You can see the deviated septum. And then after surgery here, quite a straightening. This was me 24 hours, or sorry, the day of surgery. Here's me 24 hours later. And we also give this out as a poster. So anyone who wants such a poster, we give this away for free. It's often used in waiting rooms or chairside in one of the operatories. In fact, it's all over the world. I've seen dentists give talks online in Australia, and I've seen my face on the poster in the background. And we have it in multiple languages. I think it's in French and Spanish and Arabic, and I think Turkish as well. So first question, what is apnea? What is sleep apnea? I like to call it wake up, gasping, choking, dying, or sleep disease. So the patients are dying. So when we record sleep apnea, we can often get the sound. I won't play this for long, but this is useful because the patient's bed partner is complaining of the snoring. And what happens during a respiratory event? Well, this is what I call the wheel of death. So as the person falls asleep, their airway narrows, you get snoring, not always, but typically. As the airway collapses, we have apnea or hypopnea, hypoxemia, hypercapnia, so low blood oxygen level, excessive CO2. The CO2 is a driver for an arousal or an awakening. Often you get pituitary adrenal activation in severe cases. That's a stimulus. The airway opens, they gasp, they choke, they snort. I've heard some really disturbing sounds in my time. I've recorded thousands of people in the hospital. You get the recovery breathing, and then the person falls back asleep and the cycle repeats itself. The highest I've seen and what, this is just one apnea. Typically in an apnea, we have a number called the apnea-hypopnea index, which is a number of apneas per hour of sleep. And the highest I've ever seen is 121, which means the person is literally, they stop breathing 121 times an hour, so twice a minute. And in these cases, they're getting more of a workout in their sleep than they are when they're awake. What we have found in research, and this is published in the journal Sleep in 2010, is reduced brain gray matter concentration in patients with obstructive sleep apnea syndrome. So there's actually research showing that you have brain damage. Here's a person, for example, I did one of these courses years ago. Before COVID, we often did a lot of weekend dental sleep medicine CE programs. And the dentist would often have a Friday night baseline with our sleep recording system. And then Saturday night, with the recording system again, but also with an oral appliance. And we would compare baseline and follow-up as part of the weekend course. And this particular person held his breath for 66 seconds. That's this flat line here, that's airflow. And when they held their breath for 66 seconds, their blood oxygen level went down 34%. That's called the desaturation. So in this instance, these are levels that at one time were thought to be incompatible with life. However, that's an adult. However, children can also have sleep apnea. And this is a study I did when a friend called me up, and she had a friend who was in tears and her daughter was snoring so loudly she could hear the daughter upstairs when the mother was in the kitchen downstairs. So I said, okay, have her give me a call. We arranged to do a test. I brought the device. The device is small. I'll show it to you later. And we did the test, and this is just 1 5-minute period of the night, but each of these events is where she stops breathing, and you can see the desaturations here. And on the next page, you can see here's a 13% desaturation. And this is a little girl who's 4 years old, very thin. Familial history, however, the father was CPAP intolerant, meaning he could not tolerate a CPAP, could not tolerate an oral appliance, ended up doing maxillomandibular advancement surgery. But the point is that children can also have it. And this is what the girl sounded like. She, I don't know how well that's coming across, but she snored very loudly. On one occasion, she became cyanotic when she fell asleep on the couch, and the mother was beside herself. What we ended up doing is there was a 15-month waiting list at the children's hospital. And you hear that a lot in local children's hospitals around all of North America. So I ended up just giving all this information to the mother, who acted as the advocate and pushed her way, got her family doctor to refer to an ENT, and she ended up getting an adenotonsillectomy. And when I followed up over a month later, after the edema went down, the mother said it was like having a new daughter. She didn't have the darkness around the eyes anymore. Her behavior was better. She wasn't missing school. So we can have, and I also recommended the mother go see a local orthodontist who understands airway, because he treated my children. So we can really have profound lifelong impacts if we take a look at the entire spectrum, not just adults, but also children. Here's one paper from 2015 published in the journal Chest, and it talks about the reliability of home respiratory polygraphy for the diagnosis of sleep apnea in children. More recently, in 2019, in the Journal of Clinical Sleep Medicine, which is the official publication of the American Academy of Sleep Medicine, this paper from Masood and colleagues was done at the Department of Orthodontics at the University of Illinois. And they actually used the Brabant metabite. And there was also a letter, a cover letter that was in the same issue, where the editor talked about the importance of this paper. So the metabite has been validated both in adults and children. And one of the important parts of this paper is that they found that just simply by using more tape to hold the finger probe, the pulse oximeter finger probe on the finger, they were able to dramatically improve the quality of their recording. So it's important for us to look at all of the spectrum of sleep disordered breathing. And of course, the obesity trends for adults, that's one of the leading factors. There's newer classifications of now more than 35% of the population having a BMI over 30. The trends from the CDC years ago, they predicted that by 2030, roughly 80 people 80 pounds or more overweight would account for up to 11% of the population. So we have some disturbing trends, and there's definitely a high correlation between obesity and sleep apnea. However, other studies have suggested that the craniofacial features are very important, because when comparing Asians to Caucasians, they found that for the same apnea-hypopnea index, Caucasians had significantly higher BMIs. So you also have to look at craniofacial features. Now, when you refer patients or you get a report back from a sleep lab, many times after a polysomnogram or a sleep lab test, you're going to see a report. And sometimes buried in the report, they'll say that all events were supine, or they'll give you a measure of how many events were supine. And that's really important, because when you have people that are predominantly having sleep apnea while on their back, you can often successfully treat them with an oral appliance, but also combine that with positional therapy. So the information you want from a sleep lab, here's some key points: total recording time, total sleep time, overall apnea hypopnea index, and it's really important you get the supine and non-supine apnea hypopnea index. I've seen a lot of times where that number, that distinction, is blown over by the sleep laboratory report. You want to have the respiratory disturbance index, which includes more than just AHI. It also includes your milder respiratory effort related arousals and flow limitation, and we'll talk a bit more about that. You want to make sure there's no periodic limb movements during sleep, or PLMs. If they're on CPAP, you want to know what the CPAP pressure is. If it's high pressure CPAP above 15, you can often combine oral appliance therapy with CPAP, and it generally cuts the CPAP pressure down by about half. And you want to find out the sleep stage breakdowns: wake after sleep onset, sleep efficiency, sleep onset latency, or how long it takes them to fall asleep. You're going to get a summary. It's going to break down a lot of this data: lights out, lights on, time in bed, much of what I just talked about. You'll get a graph. It'll break down percentages of sleep, non-REM stage 2. REM sleep for adults is typically 20 to 25% of the night. Deep sleep is often an indicator of the more deep sleep, the better. As you get older, you tend to get less and you get more interruptions. And the less stage 1 sleep, stage 1 N1, non-REM stage 1, it tends to be really a misnomer. Think of it more as light to heavy drowsiness, because when we used to wake people up in the sleep lab, about 50% of the people would only subjectively experience sleep after their first sleep spindle, which happened during stage 2. Hypnograms on the reports you're going to get back, whether you do a home test or you get lab data, it's very important that you take a look at the hypnograms. There's a lot of information on here. You're going to look at sleep staging. You're going to see arousals, SpO2 levels, pulse rate levels. You want to see a thinner pulse rate line. Here you got a thicker line, meaning more arousals going on, more sympathetic nervous system activation. Respiratory events: obstructive apneas, central, mixed hypopneas, desaturations, respiratory effort related arousals, pulse rate variability, snoring sounds, and body position. All of this is important because it's going to give you a synopsis of what's going on. Whenever you do a test, what's different from how a dentist would use home sleep testing versus a sleep lab, your typical sleep lab would do one test. As soon as they see sleep apnea, they'll put on a CPAP device called the split night study, and then they titrate the device, send the person home, and that's typically the last the sleep lab sees the patient. For a dentist, you always want to do at least 2 tests, one baseline and then a follow-up with an oral appliance. You want to take a look at weight and lifestyle changes. One of the issues in sleep labs, I've often talked to patients who have done sleep lab tests and then home tests, and quite a few come back and say, well, why couldn't I do the home test first? Outside of Ontario, most places in North America, like particularly in the US, it's funded all over the US. A home sleep test and a lab test is funded all over the US. In Ontario, it's only a laboratory test, and the government is trying to restrict the number of lab tests. So as a basis, what is sleep? I like to call it the great brainstem battle. We have an altered state of consciousness, a change in neuronal firing patterns. Even in ground bees, even in insects, we see a change in neuronal firing patterns. Consciousness is usually in abeyance, which means it's suspended, and then the body and the brain are restored. Now, the thing that's important is there is research going back to the early 80s. Stephen LaBerge at UCLA did find that you can have people that are in polysomnographic stage REM sleep. However, their mind is awake, and so they're in polygraphic sleep, in REM sleep. All the indications are in REM sleep, but what we see is that they can actually signal with their eyes a certain eye pattern to indicate that they're dreaming and that they know they're dreaming. We call that lucid dreams. That was also replicated by Dr. Bob Ogilvie at Brock University in the early 80s. So you have to be careful with the definition of sleep. Just make sure that consciousness can still exist, but it's usually suspended. I've had lucid dreams. They can be quite fun. Sometimes, though, when you try to make too much control, you can kind of lose the opportunity. But if you want to try it yourself, simple technique would be to put a band on your wrist. And every time you look at this band on your wrist, ask yourself if you're dreaming. And then one time at some point, usually in the latter couple of hours of sleep, because you tend to have more REM sleep in the second half of the night, you'll be in a dream and you'll ask yourself, am I dreaming? And then something weird might be going on, or what we call bizarre. And that's where you can often experience a lucid dream. So it can be quite fun. Particularly, Dr. Stephen LaBerge used to talk about it from a therapeutic perspective and taking control of your dreams. So you've got reduced awareness in dreaming, but it's not absent. And we have profound changes in brain waves, EEG, eye movements, EOG, and muscle tone, or EMG. And they're very profoundly different. So we are talking about a different state of alertness. Sleep researchers will often say there's wakefulness, there's non-REM sleep, and then there's REM sleep. And those are the three states of human existence. When I first started back in the 80s, this was the machine. It's called a polysomnograph. That's a stainless steel machine. It probably weighs 300 pounds. And underneath here at the bottom, we had paper, and then we would have the paper would go at a speed of 12 millimeters per second, and we would end up with an eighth of a mile of it was a huge, sorry, about a quarter mile of paper. And all of these pens are like voltmeters. So when you have the old style voltmeter and you would measure voltage like that, instead think of it on the side, and it would go like this, and the ink would spray on the paper, and sometimes the paper would tear, and you could actually tell by listening to the pens how well a patient was sleeping. So we use that in the hospital. And then in the early 90s, we would take the signal out, put it into a computer, and do an analog to digital conversion. And we started a product called Sandman. And at the Royal Ottawa Hospital where I worked, I was the first person in the world to use that. And so myself and the co-founder of Braybon, we started the Sandman polysomnogram system in the early 90s. And that became the #1 sleep system in North America, or during the 90s. And there was a huge explosion in the growth of sleep labs. It was truly a hockey stick curve. It was quite amazing to experience. And in the early 2000s, we created a little device called MediPalm. It was about this big, about the size of your iPhone, but a lot thicker, about 2.5 centimeters or 1 inch thick. And the problem is that we were too far ahead of the technology curve. People looked at this and thought, oh, that's neat. It's a pulse oximeter. And we're like, well, yeah, it's a pulse oximeter, but it's also your head box and your amplifier and your computer screen, and it does everything, but it's in the palm of your hand. And nobody believed us. So we ended up spending more marketing effort trying to convince people that what it was. Then nowadays it's, people accept it, but back then we were too far ahead. So in technology, you often want to be 6 inches ahead, not 6 feet ahead, so to speak. Now, the first sleep stages were described in 1937 in the Journal of Experimental Psychology. And this was really, really neat stuff. Even the writing style was quite different, fun to read. And they called the stages of sleep A, B, C, D, E. And now today we call it stages wake 1, 2, 3. In the old days, we had a stage 4, but that was changed in 2007. And then, of course, REM sleep. And here's what we look at when we look at the brainwave frequencies. So I was involved in some research in the early 90s on DC cortical potentials. Very, very slow stuff. Nobody really looks at that anymore. Well, I mean, researchers do, but clinically, they don't really go below delta, which is your deep sleep. Theta brain waves. Everyone's probably heard of alpha. Alpha waves are measured in the back off the occiput on the occipital lobes with eyes closed, relaxed, wakefulness. Typically, 80% of humans will generate alpha waves, and we look at that to help identify sleep onset. Beta waves would be alert, awake brain waves with low voltage, desynchronized EEG, and then faster frequency beta. There is a frequency called gamma, but typically only looked at by researchers. Standard electrode placement. So when you go into a sleep lab, they put electrodes to measure brain waves, eye movements, muscle tone. They go on very specific parts of the body. We do it on the chin and just under the chin, called mentalis and submentalis. And this is from the 1968 Rechtschaffen and Kale scoring manual. That's been since revised in 2007 by the American Academy of Sleep Medicine, and they've come out with multiple versions since then. So we put all these electrodes on the person's head. We put sensors on their face, cannulas. We put belts on the abdomen, over the diaphragm for diaphragmatic activity, on the chest for intracostal activity. We put a finger probe on for pulse oximetry, electrodes on the legs for anterior tibialis EMG, electrodes on the shoulder and chest for EKG. And then we tell people, oh, we put them in a strange bed with strange pillows and with an infrared camera watching them, with a stranger watching them, and then tell them, okay, now go to sleep like you do at home. And that often doesn't happen. So we often will get the first night effect. And when the person does fall asleep, sometimes it takes them longer, which is common. Typically with a sleep apneic, though, their problem is more staying awake, not so much falling asleep. So you could put some of these people underneath a Mack truck and they'd fall asleep. And we would divide the sleep stages. It started in 37. And then in 1953, Azarinsky was the graduate student, and he was working with Dr. Nathaniel Kleitman at University of Chicago. They discovered REM sleep. And then 1957, Bill DeMett worked with Dr. Kleitman, and they revised the scoring manual to include REM sleep. 1968, Rechtschaffen and Kales was the first internationally recognized sleep stage scoring manual, which was then revised in 2007. However, the bottom point is that we are still fundamentally using the same technology as the pioneers from 1930s. And we can then break down the sleep into different stages here. Stage 2 sleep is low voltage, desynchronized EEG. The brain eye movements are not doing too much, and the muscle tone is kind of tonic. And then as you go into deeper sleep, you get more high voltage synchronized brain waves, which represents the summation of inhibitory and excitatory postsynaptic potentials. And then you have the EOG. This is not eye movements. This is just artifact being picked up off the frontal lobes because you have high voltage EEG. And then the muscle tone goes down a bit and then goes to its lowest point, what we call muscle atonia during REM sleep. And you have low voltage desynchronized EEG, which is more similar to stage 1 sleep in humans. In animals, the REM sleep EEG looks more like a wakefulness, which is why in the animal literature, they'll often call it paradoxical sleep, or as Dr. Jouvet coined the term in the 60s, le sommeil paradoxical. But the important point here is you've got rapid eye movements. So with the exception of the eyes, so you got ocular motor activity and the diaphragmatic activity, the rest of the body is paralyzed, because at the alpha cord motor neurons at the base of the brainstem, at the top of the spinal cord, these alpha cord motor neurons are hyperpolarized, which means they're not supposed to fire. But in around 1986, researchers at Hennepin County in Minneapolis, they discovered that there are some humans, particularly older males, who actually don't have that hyperpolarization effectively working. So instead of that door being closed, where you've got an active brain sending signals down to the spinal cord, but the spinal cord door is closed, that door was faulty and signals were going through. And these people were often acting out their dreams, and quite a bit was violent. But you would have cases where, you know, a 70, 72-year-old man would bolt straight out of bed and go head first into the wall. And then this person would have to, you know, tie themselves down to the bed. And what a way that is to live. And then once they came up with this new sleep disorder, it's called REM behavior disorder. Now they're actually able to treat it pharmacologically. But I remember having such a case once in the hospital where the sleep physician, the medical director, brought the couple in, and the poor woman had a black eye because, you know, these people were often violent. So he socked his wife during this REM sleep period. And, you know, the neighbors and friends thought, what the heck's going on in that marriage? And they were going to see psychotherapists and all sorts of stuff. And finally, we were able to make the proper diagnosis. It had nothing to do with psychology. It had purely to do with his physiological behavior in his brainstem. And when they came in for the follow-up, the physician brought them back to the lab, and I played the actual video because we had the infrared camera. And this is a case where that type of person needs to be in a sleep lab. So as we go on during the night, there are people that must go to a sleep lab for that diagnosis. And you must have a physician make the diagnosis, because dentists cannot make a medical diagnosis. And we'll talk more about that distinction as we go on. So for example, if someone has REM behavior disorder, or if someone is sick, one time our tech support people had a phone call from a dentist who wanted to know how to use supplemental oxygen with our Metabite home sleep device. And I had to say, well, time out. No, you can't do that. That's a sick person. If the person's already on supplemental O2, they need to be in a sleep lab because they're already sick. And that's a complicated case. You don't want to deal with complicated cases and be liable for that in a home test. You want that person to go to a sleep lab. So in the sleep lab, we gather all this information. And here you see I'm describing the different brainwave frequencies, the different heights, the different frequencies, and how they all correspond to the non-REM sleep cycle. That non-REM sleep cycle, the first half of the night is predominantly deep sleep, the second half predominantly REM sleep. And we know that as people progress from non-REM to REM and back, you're going to have probably about 3 to 4 good REM periods, you hope, during the night. And this is what it looks like here. Slow wave sleep, often deep sleep is called slow wave sleep, REM sleep, and then in the second half of the night, stage 2 sleep and REM sleep. And that's your typical sleep hypnogram. When we talk about the technology that we're using in the home, the nomenclature that's often used, or the schema that we often use, is we categorize it by type or level 1, 2, 3, and 4. Think of type 4 as an oximeter or a glorified oximeter, maybe with an airflow channel. Type 3 adds cardiopulmonary. So you must have at a minimum airflow, respiratory effort or ventilatory effort, and either blood oxygenation, and either pulse rate or EKG. So those 4 things here: thermal airflow, pressure, or air pressure airflow. It doesn't distinguish one or the other. Ventilatory efforts and body position and snoring can often be added. A type 2 is similar to a type 1. The difference being is that there's no one watching, so it's unattended recording. In a type 1, you can have the same technology recorded, but you have a sleep technologist watching all night long. So I've done thousands of type 1. This is an example of a type 1 that can also be used as a type 2. So here in a sleep lab, we'll have brain waves. F stands for frontal lobe. The 4 is the even numbered side, and the M stands for mastoid. So M1 stands for behind the mastoid process, behind the left ear. Reference to the FP, which is about here. And that's using the 1020 electrode placement system, which is an international technique that's used in neurology and neurophysiology all over the world since 1958. And so you've got frontal, central, and occipital. So frontal, central, there's no central lobe, but we say that's over the central sulcus of the brain, and then occipital. So these are all even numbered, F4, C4, O2. So that's all on the right hemisphere. And then E1 is left eye and E2 is right eye. And then chin, EMG. And then EKG, we typically want to do a modified lead 2 or some type of lead 2 because it's the best opportunity to get cardiac arrhythmias. And then your legs. And then we can often do snoring, airflow with a thermistor, which is a temperature technology, airflow with a pressure cannula. It's a pressure, it's a force measurement, chest effort, abdominal effort, blood oxygen level, pulse rate. So SpO2 and pulse rate are optical sensors. And, you know, when you have a pulse oximeter or even a wearable technology like the new smartwatches, they'll have their LEDs on the back. There's some tricks to doing optical recording and technology. There's different types of transmission technology and reflectance technology. Sometimes if your watch is too loose, then the light the sensor won't be against the skin properly. So your reading is going to be off. You can have motion artifact. And so when you're using optical sensors, it's a little trickier. We often also want to record body position. You can do it with a sensor, or in some sleep labs, they'll use a video camera and the sleep technologist will enter on the keyboard what the body position is. And then when you're doing CPAP, you want to know CPAP pressure and CPAP flow. Sometimes they'll even measure CPAP leak. And then at the bottom, and this is a 5-minute window, by the way, right here of the entire night. So we're looking at a really long medical test. And at the bottom, this is the entire night as it goes on. And here you have a period of desaturations This black bar corresponds to 5 minutes of the entire night. And this is the 5-minute window above it. So this is the raw data we're looking at. And what you'll notice is that these thick black lines here always correspond to the supine body position that we see here on the left. So this person is textbook positional apnea. Here's a recording of myself I did for a type 2 recording. What you'll notice is that the screen here is a lot busier. This is type 1. You've got more signals on the screen. A type 1, you'd probably want at least 16 signals. Back in the day, now some labs will record 42 different signals. You can record an infinite number of things, like even carbon dioxide in millimeters of mercury. So, and here's a home test of a type 2. And so you've got one channel of EEG, EOG, EMG, which is the bare minimum. And then, of course, snoring, airflow, chest and abdominal effort, a sum, which is another measure of snoring, pulse oximetry, and body position. And here you have a K complex, which is definitive of stage 2 sleep, and then a sleep spindle. And that's why it says N2 over here, which stands for non-REM stage 2 sleep. So here, when we look at the sleep stages, this is a good example of stage 2 sleep. We see the spindle and the K complex. And then here we have deep sleep, and you can see the amplitudes completely different. Slow cortical activity synchronized. So you have a high summation of IPSBs and EPSBs. And then we have the brain waves picking up the artifact of the eye movements picking up the artifact of the brain waves, and then the muscle tone. And then here, of course, we have rapid eye movements here. And then we have very low muscle tone activity. And that's REM sleep or stage REM sleep. Here you have wakefulness with low voltage, desynchronized high frequency EEG, and a much higher EMG compared to the REM sleep. And this again would be stage 1 sleep at the bottom, which I like to call light to heavy drowsiness. So whether it's stage 1 or whether it's a type 1 or type 2 recording, you're going to get very similar information. Think of the type 2 as just a home test using similar technology, but no sleep technologist physically in attendance watching. That's really the primary difference. Now, a type 3 is cardiopulmonary. So this is the product that we make. It's been around since 2006, and that's literally the size. So you wear it on your body, typically on the sternum. Although with 2-year-olds in the past, we did use it on the back, mounting it on the back, only because sleeping prone or on the stomach is common in children, but rare in adults. So what we did with the child is we just mounted it on the back and inverted in the report the supine and the prone positions when reporting. So here you can see less information on the screen. So what we do here is we sample audio, so we can actually record the raw audio and listen to the person while they're sleeping. We get a volume derived from the audio. We can then get snoring in terms of frequencies. We can get from the cannula. We get airflow from the cannula. That's your pressure signal. And then you get thermal airflow for temperature, chest ventilatory effort, abdominal effort, and then the sum, which is a sum of chest and abdomen, pulse oximetry. And then this is an error. It says standing, but it was probably the position, the way it was mounted on the body. Because when you're dealing with an accelerometer, even if it's on your phone at a certain position, the 3D accelerometer, the 3-axis accelerometer, has to make a decision as to what position it's in. It's just a number that's chosen and programmed in by the engineers. So there's nothing going on here. What we see is sinusoidal activity. It's a pretty boring page. And you can simplify that even further. Now there's less stuff on the screen, and you've got only one flow channel and one effort channel. And otherwise you still have pulse oximetry and it's reading supine. So it's still a type 3, but just fewer channels. So that really is a breakdown of types 1, 2, 3, 4, with the sleep labs using type 1 and the home test predominantly type 3, and some people using type 2. The type 2 requires usually the application of electrodes, and that's a lot more complicated. What I found over the last 20 years is as soon as you start adding electrodes, it brings up an order of magnitude in sophistication for most lay people. When do you want to use a type 3 snoring and apnea test? So this is when, as a dentist, when would you want to do it? First and foremost, the bed partner complains of snoring. It's typically not the patient, because you cannot ask the conscious mind what the unconscious mind is doing. So you typically talk to the bed partner. Now, sleep bruxism. If you're looking in the mouth and you see abfractions on the teeth and you got wear and tear on the teeth, start thinking sleep bruxism, because there is an overlap. Now, I'm not saying that everybody has sleep apnea or everybody has sleep bruxism has sleep apnea. No, I'm not saying that. I'm saying there's an overlap. You will find a good number of people that have sleep bruxism also will have sleep apnea once you start having that conversation. Scalloping of the tongue. If we think of the tongue as the animal and the teeth as the cage, and that tongue is being pushed against the teeth to maintain a patent open airway, then we have scalloping of the tongue. And on that poster I talked about earlier, that's actually one of the clinical symptoms. We talk about abfractions, we talk about scalloping of the tongue. A lot of what I'm talking about here is on that poster. And so I've had some dentists who we work with who have the poster in their operatory, and they'll look in the mouth and they'll start talking to them, and they'll measure their neck circumference. Oh, you're over 17 inches and you're male, and you're over the age of 50. And by the way, I'm looking in your mouth and you've got some abfractions and you've got scalloping of the tongue, and you see this poster over here. Well, you've already got 5 of these 10 things on the poster. Does your bed partner ever tell you that you snore? And oh yeah, then that opens up the conversation. And often your hygienist can do this. Your hygienist can start the screening process. And then when you go in and have that post cleaning conversation with the patient, then you could pick it up from there. So the bed partner reports, I can't emphasize how important that is. Even if you're doing an Epworth sleepiness scale, that's 8 questions ranging from 0 to 3. And a score of 24 is maximal sleepiness, and anything above, I think 10 is clinically significant. You want to often get the bed partner to fill out the question, the Epworth sleepiness scale, in addition to the patient doing it, because you'll often get a different score, and often a higher score when the bed partner fills out the Epworth sleepiness scale. Oral appliance evaluation follow-ups, you want to use a type 3 recording for that. And then even if you get a referral from a local sleep lab or a local physician, always, always, always do your own baseline test, because the technology that they're using is going to be a little different. Even though fundamentally it's the same, there's always a little difference in the technology. Epworth sleepiness scale here, I'm recommending 8. You can do 8, you can do 10, whatever you're comfortable with. Morning irritability. If you have a person who's complaining of morning irritability, often another indicator for you doing a home test. Atrial fibrillation. My father-in-law was a great case where he had undiagnosed severe sleep apnea, even though he was a patient at the local heart institute, and he had atrial fibrillation that could not be controlled even after electrical cardioversion. And I said, hey, we got to do a Metabite home sleep test, because you might have sleep apnea. He goes, you see sleep apnea all over the place. And I said, well, yeah, I do, because it is. It's a problem. It's profound. And what do I know, right? I've only got a PhD specializing in this. I don't know anything about this, but I managed to talk him into it. And he was not a technically sophisticated guy, but he did the test, figured it out. The next day I downloaded the data. It was on a Monday morning. I think it was a Victoria Day holiday, like over 10 years ago. And sure enough, he had an AHI of 44. I'll show you I think I've got the data later to show you. Gout is often, can also be an indicator of undiagnosed sleep apnea. And attention deficit hyperactivity disorder. Supposedly, some of the research claims 50% of children undiagnosed are actually with ADHD are actually undiagnosed sleep disordered breathing. Type 2 diabetes linked to obesity, linked to sleep apnea, and then gastroesophageal reflux. So people with sleep apnea usually don't complain of the sleep apnea, but they often present with other symptoms. So with a type 3 test, you can do lots of different stuff. You can screen for bruxism, for EKG abnormalities, snoring, periodic limb movements. Typically, though, as a dentist, you're typically going to do bruxism. And we have one prosthodontist comes to mind. All of her patients get screened for sleep bruxism. And snoring is another common one. PLMs is not usually as frequently done, although sometimes I've seen sleep labs do it. And we work with some cardiologists who will do some screening, but they are often using Holter equipment, Holter monitors for long-term EKG monitoring. Oral appliance baseline versus follow-up for cases where you have mild to moderate sleep apnea or CPAP intolerant patients. You want to make sure that the oral appliance is working. One of our local sleep lab docs told me years ago, he likes the idea of his person having a metabite, because then they know that he just wants to get a copy of the report. So then they know they're taken care of. CPAP, that's another for auto CPAP and CPAP titration, home testing or combination therapy. These are things that you can do for home sleep testing. So let's take a look at the airflow, sinusoidal activity or quasi-sinusoidal. This is normal breathing. You get about 10 to 16 breaths a minute, roughly 5,800 breaths a night, and you're going to have the sleep stages. And in a healthy, good sleeper, I've probably over the years done thousands of tests, and I've probably only seen an AHI of 0 in maybe 2 people. And they were typically they were athletes. You get a drop in muscle tone at sleep onset, which increases flow resistance, and that's during sleep. And the sleep state is needed for airway problems. You don't have sleep apnea when you're awake. Although sometimes these will be the people that you lie back in the dental chair and they start saying, oh, I can't breathe. And that's often an indicator as well. So what happens during sleep apnea? Well, the quasi-sinusoidal signal becomes a flat line, and so it gets replaced by this, and that's your obstructive sleep apnea event. We say that they're flatlining, and you want a minimum duration of 10 seconds. For children, it's 2 breaths. For adults, we go by a minimum of 10 seconds. And if you're measuring anything other than airflow, it's an indirect measurement. And we have different techniques. We have the nasal pressure technology and the thermal airflow technology. And the difference, you can see them here. This is the airflow, looks flat on pressure. You got a little bit of flow, and you have paradoxical breathing. So here during the recovery, 1 + 1 = 2. However, during the event, when you have paradoxical breathing, where instead of the abdomen and thorax going up and down together, they start going paradoxically. And this is where you get 1 + -1 = 0. And that's why you have a flat line on the sum channel, typically followed by an arterial or oxygen desaturation, a peripheral, the SpO2 stands for saturation of peripheral oxygen. Sometimes you'll see it reported as SaO2. That's incorrect on some reports. SaO2 stands for arterial saturation, which you have to actually draw blood with a needle and send it to a blood gas test at a lab. So this person here in this 5 minutes, they woke up 1, 2, 3, 4, 5, 6, 7 times. Their AHI was 100. So this person is dying in their sleep. They don't know it because they're unconscious. And during a hypopnea, the quasi-sinusoidal waveform is replaced by a little bit of airflow. You still have a desaturation, which you see here. The blood oxygen level drops after the events. And here you've got a person who has an AHI of 13, but the respiratory disturbance index, which includes milder forms of sleep disordered breathing, was higher at 23. Here you have another person, same idea, multiple events. You'll also notice the pulse rate goes on. So you have the arousal from sleep, and you get pulse rate amplitude changes. So you got the autonomic nervous system arousals. And this is what happens. So if you know everything on the front of this sheet, you can have an intelligent conversation with any sleep technologist or sleep physician. Now, non-invasive detection of respiratory effort-related arousals. So we have apneas, we have hypopneas, because if we go here, we have the apneas, which are most severe, total cessation or more than 90% closure. Hypopnea is more than 50% closure. Flow limitation is what we're going to talk about now. Those are called, we use respiratory effort-related arousals, and that gives us flow limitation. So on an endoesophageal catheter, we sell those products, but they're typically used by sleep laboratories of excellence, like Stanford University Sleep Lab, and you typically have to use a topical anesthetic. You stick the catheter up the nostril, through the nasal pharynx. You've got to have an emesis basin there. because there's often a gag reflex as the person swallows the catheter, and they drink water while they're swallowing it. And then you inflate the balloon and it's got to stay there all night, and you hook it up to a pressure transducer. Well, that's what's going on here where it says esophageal pressure. So this is a study where they published that, and they also talked about flow limitation with a cannula. So in the 1990s, Dr. Rappaport and colleagues at New York University showed that you can, instead of having to make people swallow an esophageal catheter, which if you presented that to most patients when they walked in the sleep lab, they'd run screaming out the door. They said, "You're going to stick that in me? No, no way. I'm out of here." So what we do instead is we just use a little oxygen cannula, just like you see on TV. And I prefer a cannula that has or an oral component as well, because then you got a chance of picking up mouth breathing. And what they've shown is that you don't have to use an esophageal cannula. You can get the same thing with nasal cannula, which is what you see here. And the filter settings are important for your home sleep test. They're going to be set already. Sleep lab technologists do it a little differently. They should have the competence to make sure the signal is done correctly. And you can see here, this is the cannula signal. This is what we get during that quasi-sinusoidal normal flow. It starts to change. You get a decrease in amplitude, no flow limitation here. Now we start getting some inspiratory flow issues. And then once you start getting this plateau on the inspiratory waveform, it starts to flatten the reduction in amplitude, then you got flow limitation. In other words, limited airflow. And that's what we use to count respiratory effort related arousals, which I've circled here. These are RERAs. And you can see there's a decrease, but there's no real desaturation of 3% or more. So we can't call them a hypopnea. They're a more subtle flow, a more subtle upper airway sleep disorder breathing event. And we call them respiratory effort related arousals. So if I block out the other stuff, and you just look at here, you can see there's changes in ventilatory effort, changes in airflow, and sometimes mild 2% changes in blood oxygenation, but also increases in pulse rate. So that's your arousal. So this person is still having issues. You'll often see this with menopausal women. And you know, you could treat sleep apnea with CPAP, you could treat it with positional therapy, you could treat it with an oral appliance, you could even treat it with estrogen. But you know, so when women hit menopause, they are much more likely to start develop sleep disorder breathing and snoring. But you could treat it men with estrogen, but then they start developing mammary glands, and that's a side effect they don't want. So what we do is we recommend oral appliances, CPAP, positional therapy, and so on. And we score, these are the same events. You're looking at the same screen, 5-minute window. This is a 6 minutes, sorry, it says 360 seconds. So that's a 6-minute window. And we mark them as RERAs, or respiratory effort related arousals. And that's your flow limitation. And on the reports, you'll see it all added up. We can count the number of central apneas, obstructive apneas. Any good home sleep test will give you all this. The sleep lab test will give you all this. But what you see here also is we see flow limitation. And we can see the snoring in audio. A lot of sleep labs won't even bother with a measure of snoring. They won't quantify it because snoring, like Dr. Guillemino used to say, snoring is an alarm telling you that there's something wrong with breathing during sleep. But most sleep labs don't care. They just, you know, will say, yeah, loud snoring was detected. I'd like to quantify it. And I'll show you later where we can use oral appliances to actually reduce the snoring volume, which is the #1 complaint of the bed partner. So airflow during sleep, to summarize, this is your sinusoidal or quasi-sinusoidal airflow, no obstruction. This is what you want. And then this is the other end of the spectrum. This is your apnea. Here you've got your hypopnea. If we add an effort belt, we can now get central obstructive mixed, because now we know if the person's continuing to breathe, if they have ventilatory effort, because we know that the phrenic nerve from the brainstem actually innervates the diaphragm. Remember at the beginning, I said the diaphragm continues during REM sleep, and so do their ocular activity of the eye muscles. And there's newer technology now, implantable pacemakers like the Inspire is the first in the world to get through the FDA, where they have an invasive, it's an implantable pacemaker that actually stimulates the phrenic nerve to treat central sleep apnea. So here's a really good case of central sleep apnea. No airflow on the cannula, no ventilatory effort on the chest or the abdomen, and a flat sum. So this is an excellent example of central sleep apnea. Here's another example here. And dentists cannot do anything for central sleep apnea. But if you see it, you send the person straight to the sleep lab physician. Here's a case of a dentist at one of these courses who actually got worse on CPAP. With CPAP, his apnea-hypopnea index was 31, 24 without CPAP on the baseline night. He got worse with his CPAP. Again, this reinforces the importance of ongoing monitoring because you're never cured of sleep apnea. What you're doing is you're managing a disorder. You're managing something because if the person changes their weight, if they start wearing a different type of appliance, you need to monitor what's going on. So that's the importance of looking at central sleep apnea. We add SpO2 because, which is the finger probe typically. It could also be an earlobe probe, could be a wristwatch. There's pros and cons of where you mount it on the body. And when we do that, we're now able to look at blood oxygen levels. We add a second effort belt. We can get paradoxical effort that I talked about earlier. And this is your type 3 recording. Add body position, and this is what you have. A snore microphone to quantify snoring, a cannula and a thermistor for 2 different types of airflow, particularly for children, ventilatory effort belts, and a measure of blood oxygenation and pulse rate and position. And this is typically what a dentist would want to use to monitor the effectiveness of oral appliance therapy. And sometimes you can also see the arousals from sleep if we're measuring brain waves as a type 2. Note the pulse rate variability here, where you've got these off the finger probe. That's a measure of arousal. You can see it here if we zoom in on it. And remember, RERAs, respiratory effort-related arousals, are the mildest form of sleep-disordered breathing, and they typically are 10 seconds or longer. They lead to an arousal from sleep, and the sequence of breaths do not meet the definition of either hypopnea or an apnea. If we zoom in on it, though, you do have an arousal, and you can see the post-arousal pulse rate variability increasing here. Now, position I mentioned earlier, this is important. If you have a person who has a non-supine apnea-hypopnea index that's half the supine, so in other words, the supine is at least twice as much as a non-supine, you've got a case of positional apnea. And here you see that this person's AHI, while supine is 6.4, they were 54% of the night. Non-supine, they're 2. So you've got mild sleep apnea, supine, and within normal limits, less than 5 non-supine. Now, that's not to say the person still might not be pathologically sleepy, even if their AHI is less than 5. Everybody's will vary. You can have case-to-case, person-to-person variability quite a bit. So to summarize, here we've got back to that table where we've got the difference between type 1 sleep lab, type 2, similar, same technology with no sleep technologist, and then type 3 being cardiopulmonary with no sleep technologist, and type 4 being an oximeter or maybe a glorified oximeter, again, with no one there. Now, you're often going to hear people say, well, a sleep lab test is the gold standard. No, it's not really, because there is no physiologic gold standard for sleep apnea. It's not like when you do a radiograph and you see some abnormal indications on the imagery, then you send the slides to the radiologist, and then they do a biopsy, and the biopsy is the gold standard. Sleep apnea is not like that. It's the same technology, and because we actually create the technology, we understand it intimately more. But in the published research, and this is a very important article from 2012 in the journal Sleep, and a multi-site study comparing home sleep testing to laboratory or PSG, polysomnography, they concluded that a home-based strategy for diagnosis and treatment compared with in-laboratory PSG was no better, had the same, it was not inferior in terms of acceptance, adherence time to treatment, or improvements. So what can a complete type 3 home sleep test tell us? Now that we know it can be comparable with a laboratory test. Well, we know obstructive sleep apnea, central sleep apnea, mixed apnea, which is a combination of obstructive and central, complex apnea, which involves CPAP, positional apnea, where they're mostly supine, hypopneas, RERAs, flow limitation, primary snoring. We can evaluate bruxism, and snoring, again, about 50% of the population, #1 complaint. And I like to ask, why do Black widow spiders eat the males after mating, and thus to stop the snoring before it begins. And you wouldn't believe how many times I've been at trade shows and meetings where I would say, well, if you can help my husband with his snoring, and you get that a lot. Snoring is common in animals. Sleep apnea is not. That has to do with the curvature of the upper airway and the flexible, collapsible upper airway that humans have that enables us to produce speech. The higher primates will not have sleep apnea. A potbelly pig with a BMI of 65 will not have sleep apnea because it's a straight airway from the snout all the way back to the lungs. It's not a curved airway. It's straight. It doesn't have, and they can't produce speech. So they don't have the curvature, don't have the flexibility and collapsibility. We know that from research at Queen's University in 2003, the chance of having apnea is lower if you're breathing nasally rather than orally. And here you can see that this is the respiratory cycle, and you can have snoring both on inspiration, and then there's a slight pause and expiration here. And that slight pause where I'm pointing at the arrows here and here, that's the point of maximal collapsibility in the upper airway. And the provent, which I believe is now called the theravent, that's actually why the mechanism of action as to why it works, because it maintains the pressure and prevents that collapse in the upper airway. And in the snoring table here you see a baseline, and here you see a follow-up with an oral appliance. And this is why I like to use quantified snoring with the microphone placed here at the nasion between the eyebrows, because it's always equidistant to the source of the snoring when it's coming out of the mouth and nose. And the nice thing is you can see here that they spent 1.5% of the night at really loud snoring, 90 to 100 decibels, with the oral appliances down to 0. Look at the drop from 80 to 90 from 4% to 0, 70 to 80 dBs from 4% to 0. And you get the same on every measure. So this is a really good example of what you want to do with a follow-up. I mentioned my father-in-law earlier. Here's a case where his AHI was 46, and you can see this is supine. He's got profound sleep apnea here with a couple tennis balls, positional therapy. We got him down to 4, which is borderline. So we combined oral appliance therapy with positional therapy and really helped him out. And his atrial fibrillation improved after that. So sleep bruxism, you can measure EMG with that. And why do you want to do that? Is because if patients present with temporal mandibular disorders, you see abfractions of wear and tear in the teeth, the research suggests that sleep apnea symptoms actually precede the first onset of temporal mandibular disorders. And sleep bruxism may be associated with sleep apnea. And you can see here on the recording that this person would wake up and then grind their teeth. And you can actually quantify that. And in this 5-minute window, they did it 1, 2, 3, 4 times in 5 minutes. And we can actually calculate the bruxism index. So to summarize the types of sleep apnea and sleep disordered breathing, this is what you expect with normal flow and effort cross-section, flow limitation, hypopneas, central apneas, obstructive apneas, and mixed apneas. And we break everything down into different indices. And remember, for peds, an AHI of 1 is clinically significant. 1 to 5 is considered mild, 5 to 10 moderate, and 10 or more is severe for children. And just a few quick case studies before I wrap up. You'll often see people say these sleep appliances don't work. I get that from the sleep labs. I have to actually talk to them and tell them this is my experiences are. And so we know, based on research out of Australia in 2013, are you better off wearing something that works well? CPAP does work. The problem, the Achilles heel, is compliance. And what they've showed is that in the real world, Dr. Van der Weken from Antwerp, has shown that in the real world, there's no difference. CPAP and oral appliances have the same mean disease alleviation level, because in the real world, CPAP works better, but people don't use it as much, whereas oral appliances might not work as well on the measures we record with our home sleep testing and lab testing, but people wear it a lot more. So the compliance is much higher. But in the real world, what we see is that it's about the same in terms of mean disease alleviation. And you can see here on this CBCT scan of my head that we had an 86% increase in the anterior posterior area when I stuck the appliance in my mouth. Here's a recordings we did on one of those continuing education weekends, and you can see some profound improvements in this person here. They went from an AHI of 22 to 0.3. You can see the drop right here. This person here, by the way, was on CPAP, and that's why they got worse. The only person. So Friday night, they wore their CPAP. Saturday night, no CPAP. But even with the oral appliance, there was still borderline at around 5.4. So lots of evidence that it works. Here's a case we did it at a course in Dallas many years ago, where the person went from a Friday night test of 33 with the appliance Saturday night down to 3. This is the printout here. You can see the total number of desaturations, 170. The next night down to 16. So we got fantastic results. Baseline mean snoring is 70. Remember, this is a logarithmic exponential scale down to 66. That's a profound improvement. Case 2, 22 to 0.3, the one I just talked about. This is the hypnograms of the entire night data. And you can see the same thing from 63 desaturations down to 1. So a profound improvement. We know it works. We have lots of data showing that these work. As I wrap things up, I just want to emphasize diagnosis versus monitoring. A dentist cannot diagnose sleep apnea. Only a medical doctor must diagnose sleep apnea, preferably a board-certified sleep specialist. Some of the provincial health regulatory bodies, the medical colleges, actually will provide letters of kind of a credential, if you will, that specialists, physicians in Canada typically would be like internal or chest physician specialists or internal medicine physicians, and they typically are given a letter saying, yes, you're cleared to interpret sleep testing. Now, however, a dentist can screen sleep apnea and monitor oral appliance effectiveness. And whenever I've talked to a dentist that had a question about using a home sleep apnea test, I just say, look, just screen for sleep bruxism. And if anybody asks you, just say you're screening for sleep bruxism. And if you find sleep apnea, you refer them into the medical channels. And whenever they've done that approach, they end up being like one of the top referrers to the physician and to the sleep laboratory. And you'd be really hard pressed to convince someone that a dentist is not capable of diagnosing sleep bruxism, because that doesn't make any sense to me. So the take-home message, step 1, screen, ask your patients, talk about those things we talked about on the poster, the scalloping of the tongue, the narrow airway, do you snore, the stop bang test, do you snore, are you tired during the day, do you have high blood pressure, anyone ever tell you have sleep apnea, that's your stop. What's your body mass index, if it's above 30, what's your age, if it's above 50, what's your neck circumference, if it's 17 or more inches, and what's your gender if you're male. So if you score 4 more out of those 8, and they're yes or no answers, chances are you need to be screened for sleep apnea. We actually have questionnaires that we use for cloud reporting as part of the whole process. The step 2, home snoring and apnea test. Do you have it? Get the data, get the actual physiological data. Are you dying in your sleep? And you can do a consent form as well. I always recommend that, both for the home sleep testing and then even, of course, a consent form before the oral appliance is done. And then you're finished. You can send everything up to the cloud if you don't want to look at all of the sophistication of the waveforms and the numbers yourself. There's actually services available for that online where you can actually get an interpretation report from a sleep physician. If they do a telemedicine session or a face-to-face like this with the patient, a physician is actually permitted to then write a prescription. And now that they've got a face-to-face, they write a prescription. It could be a prescription to do oral appliance therapy or CPAP. They can go either way, depending on the cutoff. The American Academy of Sleep Medicine will use a cutoff of 30. I know some physicians who would be a little more conservative and use a cutoff of 20. So here's our real quick clinical workflow. You got to do your comprehensive intake, do a baseline test. If they're severe or moderate, go to the sleep lab for CPAP. However, a good chunk of those CPAP patients will be intolerant to CPAP, and that's like low-hanging fruit. So always, even if you have patients that are on their CPAP, if they're not using their CPAP, they may be a candidate for oral appliance therapy. Certainly for the primary snorers, mild and moderate patients, you can get a letter from a physician for an interpretation and do actually make an oral appliance. And there's actually technology now on the market for objective oral appliance compliance testing for that oral appliance. And you always want to do a follow-up test. Follow-up and treatment follow-up are very important, and that typically is not done by sleep laboratories. So that's pretty well the summary of what a dentist can do using home sleep apnea equipment. And where do you go from here? The Principles and Practice of Sleep Medicine is a sophisticated book. Another good one would be Dr. Jules Levine and Peter Sestouli, an MD, and that's a good book, Sleep Medicine for Dentists. That's another good book you can use. I wrote an app. It's called the Dental Sleep Medicine Study Guide. It's free. It's on the App Store. You can get that as another, just, to test yourself and do quizzes. And if you have any questions for me, you certainly reach out. There's my email, and I can get you set up if you want posters or whatever you want, or if you have any questions. We have people full-time on staff that take care of all that. And thank you for your attention.
Well, thank you very much, Dr. Bonato.